Hello, my name is Quentin Broussard. I'm an assistant professor of clinical sciences at Keck Graduate Institute, and today we will be discussing nutrition and renal and liver disease. The reason why we're discussing this topic today is because renal and liver disease separately are both diseases that are predominant within the community. Many patients have both renal and liver disease, and these diseases individually both play major roles in the nutritional status of patients. Patients may need different macronutrient and micronutrient requirements depending on if they have renal and liver disease. And as a pharmacist, it's important for us to be aware of those changes in regards to nutrient status in renal and liver disease patients compared to patients who do not have these types of diseases. Our objectives for today will be to discuss selected nutrition exam findings consistent with liver disease and renal disease, to define patient macronutrient and micronutrient requirements for renal disease and liver disease as applicable, and to differentiate modes of dialysis based on nutritional requirements. So we're going to start off by first talking about liver disease and essentially end-stage liver disease or cirrhosis. In regards to nutritional status and malnutrition within liver disease, approximately 34 to 82% of malnutrition incidence is present in patients with alcoholic cirrhosis. So remember, there are many different types of cirrhosis. You have alcoholic cirrhosis, you have non-alcoholic steatohepatitis, as well as other drug-induced liver diseases. In a non-alcoholic cirrhosis, the incidence of malnutrition is about 27 to 87%. So whenever you actually look at patients with liver disease, you see that there's a very high incidence of malnutrition related to liver disease, no matter what type of liver disease you actually have, whether it's alcoholic in type or non-alcoholic in type. And there are many different causes relating to why patients are malnourished in having liver disease. They basically come in three main groups. One of them is more or less limitation of oral intake. Patients may have anorexia or early feeling of fullness secondary to ascites. So if you remember in liver disease, because the liver is damaged, the liver may not produce as much albumin. And albumin is one of our proteins in the body that essentially acts as a magnet for fluid. So whenever you have less albumin within the intravascular space, or essentially within the blood, that actually causes fluid to flow away from the bloodstream and into your interstitial spaces. And one of those interstitial spaces is essentially your peritoneal space. Whenever you have fluid flow into that peritoneal space, or what is also known as third spacing, that fluid is not actually supposed to be there. And what happens is, because that fluid is not supposed to be there, patients become very fluid overloaded, and they may develop ascites, or essentially fluid buildup on their bellies, as well as other places on their body. So they may develop edema in different places. And as a result of this extra water that is essentially in the abdominal area, patients may have a feeling of feeling fuller earlier, or maybe just feeling full overall because there's just so much distension that's already in that abdominal area. Patients also with liver disease have malnutrition because of decrease of digestion and absorption of nutrients, and essentially metabolism also, if you think about it. In regards to patients with liver disease, there are many different reasons for nausea and vomiting. If we go back to item number 1, if a patient has ascites, that's going to potentially cause severe abdominal distension, and patients will become very nauseated and vomit. Patients may also not be able to digest food as well, and this can lead to a phenomenon called steatorrhea, or essentially fat within the stool, which is essentially more or less related to diarrhea. And overall, in terms of liver disease, a poor nutrition status is associated with poor survival prognosis. It's kind of debatable whether or not poor nutrition status dictates poor survival, but if you have poor nutritional status as a result of something else that's underlying that poor nutritional status, such as liver disease, for example, it might be that liver disease or whatever disease that's causing that poor nutritional status to actually cause poor survival prognosis. So overall, poor nutritional status associated with poor survival prognosis. For nutritional assessment of cirrhosis, cirrhotic patients and patients with liver disease have special considerations whenever we evaluate their nutritional status. In all patients, we always want to get a dry weight prior to calculating their nutritional needs. And in patients with cirrhosis, this can be a little bit tricky because patients with cirrhosis and in stages of liver disease may have fluid buildup on their abdomen as well as other parts of their body. And depending on the severity of that fluid buildup or that essentially ascites that's on their belly, that might dictate the amount of actual dry weight that we calculate for a patient. So if a patient has mild ascites, they should have their total weight subtracted by 3 to 5 kilograms. That 3 to 5 kilograms is essentially water weight. If they have moderate ascites, they should subtract 7 to 9 kilograms. And if they have severe ascites, they should subtract 14 to 15 kilograms. Now, as noted, obviously mild, moderate, and severe ascites are, different terms in terms of classifying ascites, and there may not necessarily be, the best methods to actually define what mild, moderate, and severe ascites are. For testing purposes, if I test you on this concept, the case will actually state whether the patient has mild, moderate, or severe ascites whenever actually calculating out the dry weight for your patient. These dry weights should also be used to calculate your macronutrient and micronutrient needs as applicable. So in regards to patients with cirrhosis and end-stage liver disease, patients with cirrhosis may have moderately low or low albumin levels as well as prealbumin levels, even in the presence of good nutritional status. And again, that's because patients with liver disease may not produce as much albumin or prealbumin. And that obviously makes these markers less reliable in cirrhosis and end-stage liver disease. You may consider collecting 24-hour continuous urine samples to measure creatinine as an assessment tool to measure nutritional status, but you have to have normal renal function to do this. And this is not something I would necessarily expect you to know for an exam, but it's just there to kind of keep in the back of your mind what nutritional status methods can be used to measure nutritional status in liver disease. In regards to energy expenditure in chronic liver disease, so this is patients who have liver disease over a long period of time and has been well developed. Predictive equations perform poorly in patients with liver disease. So if you remember our predictive equations, those are like the Harris-Benedict equation, for example. And remember, Harris-Benedict equation has been studied primarily in healthy patients. Therefore, in patients that have chronic liver disease who are unhealthy, it may not perform as well. The presence of ascites may increase resting energy expenditure by up to 10%. So obviously, because of that, you might have alterations in your calorie requirements for these patients. And many patients with cirrhosis are hypermetabolic because of this large inflammatory process that's going on in relation to their liver disease. Cirrhosis patients tend to use more fat and protein as fuel, which leads to greater proportions of fat-free mass and muscle-free mass compared to normal patients. So you might see significant muscle wasting or fat wasting with cirrhosis patients and end-stage liver disease patients. The prime example I think about in this case is patients who have chronic alcohol use disorder or who use alcohol on a regular basis. A lot of these patients who potentially binge drink, for example, may not be able to or may not be taking in as much normal diet or normal diet adequacy as normal patients. So these patients may be just drinking alcohol, but they may not necessarily be taking in food of actual sustenance, like oral food that can be normally just taken in and chewed. They might just be taking in alcohol as their pure source of caloric intake. And because of that, and because of the processes that are going on in liver disease with very pro-inflammatory responses, that can actually lead to patients with significant muscle-free mass and significant fat-free mass. And if you think about the pictures of the physical assessment of patients whenever they are malnourished back to our first talk within this class, that's essentially what some of these patients may appear like. They may appear with very low amounts of muscle mass and fat mass. In regards to liver disease, there is a debate about whether or not to restrict protein in patients. And essentially, this thought comes behind the idea that, remember, in patients who have cirrhosis, they may develop hepatic encephalopathy from ammonia buildup. And it's thought that because your proteins have ammonia groups on them, if you think about the structures of amino acids, you remember you have an ammonia group on one end and a carboxylic acid group on the other end, with more or less an R group in the middle that is different for each amino acid. Because you have that amino acid group on the end of the protein, or each amino acid moiety, essentially that breaks down and can essentially produce ammonia that can then travel up to the brain and cause increased hepatic encephalopathy symptoms. So basically ultramental status as a result of increased ammonia. Recent studies don't really support the notion of restricting protein in patients with hepatic encephalopathy. And whenever you look at the outcomes of these studies, in terms of protein allotment, patients who got low versus normal protein allotment actually had similar outcomes in regards to their hepatic encephalopathy incidence in some cases. And whenever you looked at patients who got higher amounts of protein, for example, like 1.2 grams per kilo of protein per day and 30 kilocalories per kilo per day in one study, you actually had an improvement of hepatic encephalopathy symptoms. And basically the thought behind this is better nutritional status may lead to increased clearance of ammonia, which then will obviously reduce your hepatic encephalopathy symptoms. In patients with hepatic encephalopathy, if you remember back to therapeutics of this topic, it's important that hepatic encephalopathy is appropriately treated, and this can be done using lactulose and or rifaximin. A lot of times, if rifaximin is used, it will be used in conjunction with lactulose, as this is the way that rifaximin was actually studied in clinical trials. And you can titrate to a certain amount of stools per day, anywhere between 2 to 4 per day for lactulose, depending on what outcome you actually want in terms of stool output. For patients who have protein restriction, you may consider the use of branched-chain amino acid supplemental enteral formulas if hepatic encephalopathy persists despite using lactulose and rifaximin. Remember, those formulas are essentially our liver-specific formulas. In regards to macronutrient requirements for patients who have liver disease, we typically dose patients more or less kind of like critically ill patients in regards to the caloric intake portion. So these patients require 25 to 30 kilocalories per kilo per day. And because of the last slide of what we talked about with hepatic encephalopathy, we tend to dose these patients a little bit higher than our normal patients in regards to protein. And we give these patients typically 1 to 1.5 grams per kilo per day of protein. In regards to decompensated cirrhosis, so decompensated cirrhosis is defined as cirrhosis with ascites or hepatic encephalopathy. So these patients essentially are sick. In regards to decompensated cirrhosis, liver chemistries may also show an albumin less than 3 and a total bilirubin greater than 2.5, but it also depends on the degree of severity of the actual cirrhosis. The main thing I want you to take from this slide is that decompensated cirrhosis is defined as cirrhosis with ascites and or hepatic encephalopathy. These patients have the same nutritional requirements as compensated liver disease patients, unless obviously they're critically ill. So in that case, they basically get the same nutritional requirements, 25 to 30 kilocalories per kilo per day, or 1 to 1.5 grams per kilo per day of protein. If they're critically ill, basically the critical care requirements for protein would be 1.2 to 2.0 grams per kilo per day, as we've previously discussed. In regards to other nutrition therapy and cirrhosis, fat requirements typically make up about 30 to 40% of non-protein energy. Important for alcoholic liver disease, some of the main vitamins that you actually supplement for alcoholic liver disease include vitamin B1 or thiamine, vitamin B6 or pyridoxine, vitamin B12 or cyanocobalamin, vitamin B9, which is folate, and zinc. The main two, though, with liver disease of alcoholic origin that we typically think of are thiamine and folic acid. And that's essentially, these are both essentially two ingredients that are included in what we know as banana bags on the inpatient side. So inpatient banana bags will actually contain multivitamin, which makes the bag yellow, as well as thiamine, folic acid, and as well as magnesium. In patients that have cholestatic liver disease, so this is liver disease that actually relates to more or less problems with bile duct or bile duct flow. It's important to supplement these patients with fat-soluble vitamins. So remember, those are A, D, E, and K for our purposes. For patients who have non-alcoholic steatohepatitis, so this is basically what we know also as NASH or NASH. And the steatohepatitis part just means more or less fatty liver. And this can actually result as a result of poor dietary intake, or dietary intake that relates to high amounts of dextrose and or fat. We want to obviously make sure that if patients have diabetes or hyperlipidemia, that those are appropriately taken care of. We also may want to supplement with vitamin D as needed. For patients who have ascites and that large fluid buildup on their belly or edema in general, we want to make sure to limit sodium intake to 2,000 milligrams daily, obviously to minimize the amount of fluid that travels along with that salt. Because anytime that you administer salt to a patient, you also get the fluid to go along with it. And because you get fluid buildup in these patients, you essentially get a hypotonic, hypervolemic hyponatremia, which we've talked about previously with sodium disorders. But remember, fluid restriction is not necessary always, unless patients have hyponatremia less than 125 milliequivalents per liter in terms of the sodium level. Now, you can still fluid restrict these patients. I don't think it would necessarily be clinically wrong if you did so, but per guideline recommendations, they basically say that you shouldn't restrict fluid unless your sodium is less than 125. A lot of these patients will be baseline hyponatremic, probably a lot of them in the lower 130s and the upper 120s, and that is perfectly normal for some patients. But whenever you start getting to the lower amounts of sodium concentration, it's important to take intervention. And remember, copper and manganese can accumulate in liver disease, especially whenever you administer trace elements. Copper is the one we typically think about in terms of causing toxicity, though manganese can also cause its own toxicities on the outpatient side. And it's important to consider reducing trace elements for T-bili greater than 2, though this is debatable in terms of literature that is actually out there. So you may reduce trace elements by any amount, depending on what your protocol is at your hospital or what you feel is clinically best for your patient. In terms of liver disease enteral formulas, these formulas basically are advertised by the fact that they contain branched-chain amino acids, such as leucine, valine, isoleucine, which clear ammonia in skeletal cells. And that obviously decreases the risk of developing or having cerebral ammonia. And obviously, if you decrease ammonia, you decrease hepatic encephalopathy risk. So these formulas are made to basically contain specific amounts of branched-chain amino acids to aromatic amino acids. The aromatic amino acids are the bad amino acids in this case. And that helps potentially with hepatic encephalopathy. Though remember, we discussed that hepatic encephalopathy should be managed medically first, and these formulas should be used as a last line resort in reducing hepatic encephalopathy incidence as well as severity, as it's debatable about whether or not these formulas actually clinically work in practice. And these formulas are essentially NutriHep and Suplena, as you remember from the enteral nutrition PowerPoint we discussed earlier in the course. So now we're going to transition slightly and talk about renal disease. And renal disease classifications are essentially classified into basically 2 realms. You have acute kidney injury and chronic kidney disease. Acute kidney injury per KDIGO guidelines, this is defined as any of the following. If your patient has an increase in serum creatinine of at least 0.3 compared to whatever their baseline is, if they have an increase in serum creatinine of greater than 1 point, or in regards to their baseline, they have an increase of 1.5 times their baseline. So say if a patient had a serum creatinine of 0.6 and their serum creatinine increased to 0.9, in that case, that can actually be AKI as well, even though their serum creatinine still appears to be what looks like normal. Also, if they have a urine volume or a urine output of less than 0.5 mils per kilo per hour over at least 6 hours, that is also designated as potential AKI. If they have less than 0.5 mils per kilo per hour and are still producing some urine, but still below that threshold, that can be considered oliguria. And if they have no urine output, that is considered anuria. In patients that have chronic kidney disease, remember the differences between what is called acute and what is called chronic. Acute is essentially over a short period of time. Chronic is basically long-lasting. So per KDIGO, chronic kidney disease, or CKD, is defined as abnormalities in kidney structure or function present for at least 3 months or more. And its classification is based on GFR and albuminuria. And in terms of GFR, it's staged from stages 1 to 5. In terms of albuminuria, it is staged from stages 1 to 3. I don't want you to necessarily know about these stages. I just want you to know that the classification is based off of GFR and albumin presence in the urine. In regards to GI and renal abnormalities that are associated with AKI and CKD, these are important in regards to nutritional status. In regards to gastrointestinal abnormalities in patients who have renal disease of AKI or CKD origins, you may see these patients be very anorexic. They may have nausea and vomiting. They may have altered taste acuity, gastroenteritis, peptic ulceration, ascites. Obviously, ascites for the same or similar concept to the liver disease patients. They build up fluid, though, because essentially if they are not able to eliminate fluid through their kidneys, that fluid will essentially back up and build up, which is a little bit contrasting to our liver disease patients where it's mainly due to low albumin levels. And we also see decreased protein and amino acid synthesis in patients who have AKI or CKD. In regards to renal abnormalities in patients with AKI or CKD, we see azotemia, so elevated BUN levels. We can see volume expansion because basically these patients aren't eliminating fluid out of their kidneys as much, potentially. So they may have oliguria or anuria. And we also see electrolyte imbalances such as hyponatremia, hypernatremia, hyperkalemia, hyperphosphatemia as a result of not being able to eliminate potassium and phos through the urine. We also may see hypocalcemia, as well as metabolic acidosis. And that metabolic acidosis can actually be back related to that elevated BUN. Because remember, urea is actually one reason why you may actually develop an anion gap metabolic acidosis, if you remember back to your talk previously in the curriculum about acid-base disorders. So in terms of patients who have AKI or CKD, sometimes these patients may actually require dialysis. And dialysis is also known as renal replacement therapy. Dialysis is divided into a few different types. You have hemodialysis, which essentially we think of as more or less intermittent hemodialysis, or IHD. We have peritoneal dialysis, or PD, and then you have CRRT, which is then classified into a few different subtypes. CVVH, which is continuous veno-venous hemofiltration. You also have CVVHD, which is continuous veno-venous hemodialysis, and then you have continuous veno-venous hemodiafiltration, or CVVHDF. In regards to these different modes, what I want you to know is basically about these different types and more or less how they function on a time basis. So in terms of hemodialysis is typically received for about 3 to 5 hours a few times a week. And depending on your patient's dialysis schedule, a lot of times on the outpatient side, this will actually be around 3 times a week. You may see patients come in for dialysis on Monday, Wednesday, and Friday, or Tuesday, Thursday, Saturday. At a lot of outpatient dialysis clinics. In regards to hemodialysis, it's important to note that because you only are receiving the dialysis a few times a week over a relatively short period of time compared to the rest of the week, about 3 to 5 hours for each session, these sessions are very aggressive in nature, and essentially a goal in some of these sessions is to actually take off a lot of fluid. And because of that, patients with hemodialysis may experience hypotension because so much fluid is taken off over a short period of time. If that is the case for your patient and a lot of fluid is taken off such that they develop hypotension, they can actually treat the hypotension with products such as albumin, mannitol, or even potentially fluid boluses if it has to get to that point. Another type of hemodialysis that can be done to try to minimize the risk of hypotension is sustained low efficiency dialysis, or SLED. A lot of times SLED is done on the inpatient side as it is much slower in nature, or it is sustained. and it's typically done over longer periods of time. So it may be done over, a period over the same period as hemodialysis or much longer. And what this SLED is, and compared to hemodialysis, is it's just much slower in pulling off fluid. And as a result, you may have less hypotension incidents related to SLED, though you may have some. Not all facilities that are inpatient do SLED. A lot of patients or a lot of facilities that you see out there may just do hemodialysis or continuous renal replacement therapy, as we'll talk about in a little bit. Peritoneal dialysis is another mode of an intermittent intermittent dialysis that is done. Basically, this is done with exchanges of fluid into the peritoneal space. So you have your own special dialysate associated with peritoneal dialysis. And peritoneal dialysis, compared to hemodialysis, peritoneal dialysis can actually be done in the home setting by the patient themselves. So the patients can actually be trained on how to do peritoneal dialysis, and they can actually basically facilitate their own dialysis after more or less a few attempts. What makes peritoneal dialysis very complicated is that peritoneal dialysis has to be done every day for long periods of time over the course of a day. So it is very tedious to do peritoneal dialysis, but if you want to avoid essentially having to go into a dialysis clinic or into the hospital, this is a good alternative for some patients. We don't see peritoneal dialysis much in practice anymore, though. So that's why it is not bolded here as a main type of dialysis. The other type of dialysis that you may see is CRRT, or continuous renal replacement therapy. And the main difference in why we use it versus hemodialysis is in patients who are hemodynamically unstable. So basically, if they have hypotension. So these different modes of dialysis, while I don't necessarily want you to know what the difference between CVVHD is, CVVH and CVVHDF is on a molecular level, what I just want you to know about these is that these are just types of continuous renal replacement, and I want you to know, obviously, the name of the dialysis and the abbreviation that goes along with it, and if it is hemodialysis or CRRT in nature. The big difference for continuous renal replacement therapy and why it's used in hypotension is that it takes off a lot less fluid, or it takes off fluid over a longer period of time. So essentially, your filtration that is done, or you're basically taking off a fluid that is done over a longer period of time. And because of that, patients are less likely to become hypotensive while on continuous renal replacement therapy, though it still may happen, because anytime you take fluid off of a patient in terms of their blood and filter it through a dialysis machine, that can actually result in patients becoming hypotensive. But because CRRT does this over a longer period of time and in smaller volume quantities over those short periods of time, compared to hemodialysis, where it's all kind of basically one fell swoop and you take off a few liters. CRRT is much smaller fluid changes over a longer period of time. So you might still get the same result that you get in hemodialysis, just over a longer period of time. So remember that CRRT is basically the larger group name, which is divided into CVVHD, CVVH, and CVVHDF. In regards to macronutrient requirements per KDIGO guidelines for AKI, AKI patients basically have more or less the same calorie requirements as a normal patient, so 20 to 30 kilocalories per kilo per day. Now, if your patient has AKI, and this, remember, is AKI, acute kidney injury, as defined by KDIGO guidelines, and it's non-catabolic in nature. So basically, what we mean by that is just non-ICU or non-inflammatory processes going on. If that is the case, those patients will require 0.8 to 1.0 grams per kilo per day for AKI. So basically around the same as a normal patient in the event that they're not getting dialysis. If they are getting dialysis related to their acute kidney injury, those protein requirements go up to 1 to 1.5 grams per kilo per day if the patient is not in the intensive care unit. If they are in the intensive care unit, obviously that goes up to 1.2 to 2 grams per kilo per day, and that basically is trumped. But in non-ICU patients, if they have to go on dialysis, they get at least 1.0 at minimum. And that is encompassing of all renal replacement therapies. Peritoneal dialysis is included in that case. And remember that part of the reason why higher protein needs are given in dialysis is that dialysis pulls off all things from the blood, with emphasis on the much smaller molecules. So like electrolytes and basic elements are going to be the things that are pulled off in highest quantity. However, you still have larger proteins and polypeptides that are also pulled off by dialysis. And that's part of the reason why patients who go on renal replacement therapy may require a slightly higher goal in terms of their protein requirements. In regards to chronic kidney disease and CRRT patients, in chronic kidney disease patients, their calorie needs are higher than our normal patients. They get anywhere between 30 to 35 kilocalories per kilo per day. This is patients who are on dialysis or not. In regards to protein requirements, this is where some confusion can actually pop up. In patients who are not yet on dialysis but have chronic kidney disease of some staging, we don't want to push those patients to developing kidney disease later on. And as a result, protein is one thing that actually causes renal disease to basically get exacerbated. So the higher amount of protein that you give, the worse that you can actually make kidney disease. In that case, we want to prevent their progression to end-stage renal disease. And end-stage renal disease is basically more or less stage 5 CKD for our purposes. In those cases, we don't want them to progress to end-stage renal disease, and that's why we'll actually give those patients 0.6 to 0.8 grams per kilo per day, which is lower than our traditional normal patient. Now, if they've actually progressed to the point where they need hemodialysis, regardless of if they are CKD or not, for hemodialysis patients, we want to make sure to give them at minimum at least 1.2 grams per kilo per day of protein or greater, because essentially these patients, essentially their kidneys are more or less damaged at this point, a lot of times beyond repair. And because of that fact, we can obviously not compromise their nutritional status by giving them a higher amount of protein that they will need whenever they're getting their dialysis sessions, or if they're scheduled to get dialysis or plan to get dialysis. They obviously will need a higher amount of protein because some of that protein is being pulled off by the dialysis itself. In regards to patients with continuous renal replacement therapy, so CRRT, so that includes CVVH, CVVHD, and CVVHDF. These patients, per KDIGO guidelines, should get 30 to 35 kilocalories per kilo per day. But per the Aspen Critical Care guidelines from 2016, you can also potentially just give these patients 25 to 30 and be okay. For this piece, it's a little bit debatable. The 30 to 35 in the KDIGO guidelines is a perfectly safe bet as well. So for testing purposes, either of these calorie requirements is perfectly fine to go with. For patients who have who are on CRRT, they may receive anywhere between 1.2 and 2.5 grams per kilo per day of protein. Remember, CRRT is a type of dialysis, so it will pull off protein as well as pulling off protein in regards to hemodialysis. So, because CRRT is basically 24/7 dialysis until CRRT is stopped. Obviously, CRRT has a greater propensity to pull off more protein. And because most patients who are receiving CRRT are critically ill, they obviously have higher protein requirements because CRRT essentially has to be monitored most of the time in an intensive care unit because of the high degree of nursing care that is required. In regards to fluid requirements for patients with renal disease, if you are anuric and you have AKI, and these are patients who have not yet progressed to dialysis yet, their fluid requirements are essentially 1 to 1.2 liters per day. With these patients, you don't want to basically overdo it on their fluid because they're not getting dialysis at this point. If they're getting dialysis, you can be a little bit more liberal on their fluids. If they're oliguric, if they're making urine and they still have AKI, usually fluids are not restricted in this case, unless your patient obviously has some kind of heart failure or hyponatremia. In those cases, you may restrict fluids. If your patient's on CRRT, because so much fluid is being taken off of your patient over the course of 24 hours, these patients might have very high fluid needs, and it's very important to monitor their overall fluid balance. So one thing that we can monitor is their ins and outs. So basically how much fluid is coming in and how much is going out. And you might need to keep essentially these patients what we know as net neutral. So basically the same amount in is going the same amount out. Or you might keep them even net negative, where we're trying to take off some fluid. And as a result, these patients may require very high fluid needs that may exceed the normal 1 ml per kilocal that we've typically learned about before. So obviously, if you have access to a patient's ins and outs, say if they have a Foley catheter where they're collecting the urine, that might be very useful to actually look at their ins and outs. Now, if your patient is oliguric and you have some kind of chronic kidney disease, or if you are on peritoneal dialysis or HD, regardless of the fact of if you're in oliguric, that oliguric essentially just goes with this first statement here, oliguric and non-dialysis CKD. In these patients who are oliguric and non-dialysis CKD, or if they're on peritoneal dialysis or HD, they're usually not fluid restricted because remember the dialysis is going to pull off that fluid. Unless obviously they have a condition that limits their fluid intake, such as heart failure or hyponatremia. In regards to electrolyte requirements for AKI, electrolyte requirements for patients with renal disease are very complicated and should be obviously taken as a guide. These are not necessarily the most concrete of requirements, just as basically our normal ranges that we've learned about previously are not the most concrete of requirements. So again, take these obviously with a grain of salt and use them as a guide, but remember that these are just a guide. They are not the end-all be-all for every single patient. So in terms of AKI, you should give them sodium as tolerated. Because remember, we still need sodium, as sodium has an important role in producing, for example, action potentials. And obviously, you can dose that sodium based on whatever type of concentration that you need to attain whatever sodium concentration you need, as we talked about in the sodium disorders lecture. In regards to AKI, you should only give them potassium as tolerated, and you should strongly consider giving lower than normal, if not even holding potassium. in patients who have AKI. If the patient is not able to actually urinate normally, that means they're going to accumulate more potassium as well as potentially magnesium and phos. Particularly with emphasis on potassium and phos, you really want to consider lower requirements than normal. Because these patients will just accumulate potassium and phos. And remember, there are some very bad adverse effects of accumulating potassium to super therapeutic level. And those include, obviously, the development of arrhythmias. For phos, the problem with phos is that if you accumulate too much phos in the body, that can actually result in binding with calcium at high enough levels within the body to actually develop more or less a calcium phos clot. If your serum calcium and your serum phos in the body are high enough. For patients that have AKI, magnesium, normal oral dietary intake is perfectly fine for these patients. They can get the normal amount of magnesium in most cases. Remember that magnesium or hypermagnesemia symptoms don't typically result until you're much higher than your actual serum magnesium level, typically above 4, 5, or 6.0 in terms of your magnesium level. And remember, our normal magnesium level is around 1.7 to 2.3. So if you're getting up to 4, you're already pretty much very high up there. And most patients don't actually get that high unless they have significant renal dysfunction. In regards to patients who are non-dialysis chronic kidney disease, these patients should receive 2 to 2.3 grams per day of sodium, less than 40 milligrams per kilo per day, and make a notation of this unit here, milligrams per kilo per day, if the serum levels are elevated. And again, be very cautious with potassium. Potassium can obviously potentially cause a fatal event to occur. So in some cases, you might actually, depending on what your level of potassium is and the serum trends, if the serum trends are trending up and trending up to where you predict there's going to be a super therapeutic level, the next day you should hold the potassium. In regards to phos, phos should be given in 800 to 1,000 milligrams per day. If phos ends up being elevated, you may hold phos, decrease phos, or use potentially phosphate binders such as sevelamer or calcium acetate if the phos becomes elevated. Patients with CKD of non-dialysis type can receive normal magnesium just as our AKI patients do. So the important part to just take from this slide is that you have different requirements here. Emphasis on the part about potassium and phos. If potassium and phos start trending to become to the point where they are elevated, in that case, you might need to reduce or remove all potassium and phos from a bag of PN solution if needed. In patients with hemodialysis, same concepts apply here. And particularly if a patient is on hemodialysis, particularly if they're anuric and they're on hemodialysis, you need to watch that potassium and phos, especially careful. In terms of patients with CRRT, remember CRRT is continuous dialysis. So these patients can still get normal amounts of sodium or whatever sodium concentration you deem appropriate for that patient. For potassium and phos levels, a lot of times, because CRRT will take off these electrolytes in high quantity, you may actually have to supplement them either with a rider of potassium or a rider of phos or a rider of potassium phos even on the side, or you may actually do replacements in the PN bag. It's important that you monitor levels closely while they're on CRRT and replete them as needed. Typically for CRRT, we check serum levels of electrolytes every around 4 to 6 hours. So basically, you should be monitoring potassium and phos very, very closely. Basically, that CRRT is just going to take off a lot of this stuff, and you may actually need to supplement more. You can use appropriate sliding scales if needed to replace these levels of potassium and phos. The same thing goes with magnesium. Magnesium is also going to be taken off with CRRT significantly, as CRRT is running over 24/7. So it's obviously important to monitor these levels closely and replete them as needed. In regards to renal failure enteral nutrition formulas, we've talked about these before. These patients have increased protein needs due to obviously increased catabolism, protein wasting, and in patients who are getting dialysis, obviously because of the dialysis machine taking off some of the protein. And they obviously have specific fluid and electrolyte restrictions, depending on what type of renal disease you have. In patients that have CKD who are not on dialysis yet, those patients are the ones who may benefit from limiting protein. If your patient is already on dialysis, though, it's not of any benefit to limit protein at that point because the damage is already done, and you don't want to limit nutritional status anymore. Essentially, it's a risk-benefit thing at that point, and basically the risk, there's no risk anymore because essentially your patient may be on dialysis at that point. Enteral nutrition formulas for patients with CKD not on dialysis may be protein restricted, while the ones that for patients who are on dialysis have higher protein content. So remember, your formulas basically for these patients are essentially Nepro with Carb Steady, also known as Nepro, which is probably one of the most common formulas that you see out there, or NovoSource Renal. These are typically indicated for patients with AKI or CKD who are on dialysis. Now, for the patients who have CKD who are not on dialysis yet, you may use Renal Cal or Suplena with Carb Steady. These formulas have lower amounts of protein associated with them. Here's the reference for this talk. If you have any questions in regards to nutrition and renal and liver disease, please let me know. Thank you and have a great day.